and welcome to Noon Conference hosted by MRI Online. Noon Conference connects the global radiology community through free, live, educational webinars that are accessible for all and is an opportunity to learn alongside top radiologists from around the world. We encourage you to ask questions and share ideas to help the community learn and grow. You can access the recording of today's conference and previous Noon conferences by creating a free MRI Online account. You can also sign up for a free trial of our premium membership to get access to hundreds of case-based microlearning courses across all key radiology subspecialties. Today, we are honored to welcome Dr. Sheila Sheth for a lecture entitled Peripheral Vascular Ultrasound, Venous Doppler, and Challenging Arterial Cases. Dr. Sheth completed radiology residency at Sinai Hospital in Baltimore and body imaging fellowship at the Johns Hopkins Medical Institutions. She was on the faculty at Johns Hopkins in the Department of Radiology until 2020. She is currently on faculty in the section of abdominal radiology at NYU Langone in New York City. At the end of the lecture, please join Dr. Sheth in a live Q&A session where she will address questions you may have on today's topic. Please remember to use the Q&A feature to submit your questions so we can get to as many as we can before our time is up. With that, we are ready to begin today's lecture. Dr. Sheth, please take it from here.
Okay, good afternoon. This is afternoon in the United States, in New York City, where I am. And so I hope everybody can see my screen. And so this is going to be like a case-based talk. I gave a similar talk to our fellows in the body imaging section yesterday, because I think sometimes it's easier to learn that way. So just look at the cases and challenge yourself. So let's get started. Okay, so this is my disclosure. And so what I just want to review initially, because I'm going to show some venous cases, at least to begin with. So how do we do venous ultrasound? If it's very basic, and I apologize, but I just think it's important to review this. So when we look at a venous ultrasound, I think the most important feature is actually a transverse grayscale image, where here we have the common femoral vein, you have the artery and the vein, and we want to show that with compression from the transducer, and you can nicely see on the clip, and we ask our technologists or sonographers to do clips like that. The vein should be dark, so no internal echoes, and should be very easily collapsible from just a little bit of pressure from the transducer. It's much easier to do it transverse because that you see the whole vein, you make sure you're not rolling off the vein as if you were doing it sagittally. So that's the most important portion, in my opinion, of the case to exclude a deep vein thrombosis. And then, of course, what we also look at, we put color just to make sure the vein is filling, the wall is thin. And then we get a Doppler spectrum because we want to make sure that there is venous type flow, which is relatively monophasic, but there should be some phasicity from transmitted respiratory and cardiac phasicity to the vein. And that is a very important concept because that means that there is no blockage in between a more central vein and what you're examining. And so this is what we do now. We do not do augmentation. In the old days, we used to augment in the cap, but we don't do that. First of all, it's increase the length of the examination. It's not really necessary. And, if the patient does have a clot, there's always a small risk that by doing calf compression, you can throw a pulmonary embolus. So we don't do that anymore. Okay, so let me start with this case. So this is a patient who came in to the emergent department some years ago and for left leg swelling. So here I'm showing you still images of the left common femoral vein. So here's the artery, is the vein. And when we do the compression, you can see that the vein is not compressing and there's internal echoes. So this is a pretty straightforward case of deep vein thrombosis. However, we always look at the Doppler spectrum as well. And even though it's a unilateral study, we always do both iliac veins, external iliac veins for comparison. We want to compare the Doppler spectrum in the iliac veins. And so, and I really don't want to take any credit for this case. The sonographer, had looked at everything, and based on what she saw, she did additional images, but let's see what we see. So remember, the left side is the swollen leg, and we know there is a deep vein thrombosis. But when we looked at the iliac veins, we can see, and this is the external iliac vein, you can see that there is a lot of phasicity on the right side, but the left side is much more monophasic. So the first question you have to answer is which side is abnormal? So in this case, maybe there's a little bit more phasicity than we'd expect, but this is clearly abnormal. We should not have this monophasic waveform in the legs, in the veins of the lower extremity. Yeah, you could have this could be normal in a portal vein in the liver, but it's not normal in the leg. And this is, it's mislabeled. It's clearly the left iliac vein. So based on that, what is going on? We know the patient has a clot more distally, but this portion of the vein appears open. But if you see lack of phasicity, what you have to think about is that there may be an obstruction more centrally. So we have to look in the pelvis, basically. And so she went and looked around, and this is what we saw. So she looked in the pelvis, didn't see too much, and went up the aortic bifurcation. And here you have the 4 vessels of the aortic bifurcation, which are patent. However, there is a big hypoechoic mass just adjacent to the aortic bifurcation, and you can very nicely then show it on the coronal images. There's a bunch of masses which are basically abnormally enlarged lymph nodes. And that is what was causing the lack of phasicity in the left external iliac vein. So yes, the patient had a deep vein thrombosis, but by thinking about the Doppler spectrum and looking around, we said, okay, you have DVT, but there is also something perhaps as serious or more serious going on. You have what looks like either metastatic retroperitoneal lymphadenopathy or lymphoma, one or the other. And so this is why just looking at every detail, looking at the spectrum is so important, because if we hadn't done that, we would have sent the patient, he would have been treated for DVT, but they would have missed what is probably the underlying cause of the deep vein thrombosis. This patient ended up having metastatic prostate cancer, but that, that doesn't matter. Once you find this, then you'll do a full workup, you'll do CT scan or MRI, etc. Okay, so this is a different case, a companion case, because I really want to stress this point. So this was a 42-year-old woman who presented with abdominal pain and left lower extremity swelling. And about 5 years prior to her presentation to the emergency department, she had had a radical hysterectomy for cervical cancer. So we did they requested a duplex venous ultrasound of the lower extremity. And in this particular case, all the vessels were patent. So here is the right side. Again, by now, you know what I'm driving at, right? There is normal phasicity. This is an old case, so we were doing augmentation at the time. We don't do anymore. So there is normal phasic flow in the right external iliac vein, in the right common femoral vein. And on the left side, you can see that there is very monophasic flow. And if you have both sides to compare, that's really so striking. So I think it's important to always look at the contralateral side, at least one Doppler spectrum, which is our routine. And then when we looked at the vein itself, the right common femoral vein was compressing. The left was also compressing. It was a little hard to compress because the patient had pain, but basically the vein's completely normal size, no echogenic material within it. So again, we said there is no DVT, but because we saw this lack of phasicity, we said, okay, well, we don't see anything, but the patient needs a CT scan to see if there is anything more centrally. So here's the patient's. So again, just to recap, Bilateral common femoral veins are compressible. There is flow demonstrated in both external iliac veins. However, there is what's more important, the dampened flow in the left external iliac vein with lack of normal physicity. So let's look at the next step with a CT scan. And here you can see on the axial images as well as the coronal images that the vein itself is patent, maybe a little compressed, but what is really important, this patient has a necrotic mass in the left pelvic sidewall compressing the external iliac vein, and that is the cause of the dampened flow in the left external iliac vein. So in this particular case, if we hadn't paid attention to this dampened flow, we could potentially have sent the patient home because we did not see a DVT. And now this patient, that turns out, was lost to follow-up. And unfortunately for her, what this was a big metastatic nodal mass from squamous cervical cancer. And we know that squamous cell metastases are often necrotic, such as this node. Okay, so very, very, very important to pay attention to the Doppler spectrum. And so this is basically what we need, is recognize the dampened flow on one side in a vein. You have to think about a more central pathological process. So this is an upper extremity case. So upper extremities are even a little bit more challenging